بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, now we are talking about one of the head and neck topics which will deal with the imaging of head and neck infection. And, as you can appreciate from this figure, that one of the leading causes of head and neck infection is the lesions related to tooth infection and the formation of periapical abscesses which can spread to the mouth floor and the tongue. This is one of the major issues in especially in adult population. Then the items we would like to talk about are infection of the oral cavity, infection of the pharynx, retropharynx, and the hypopharynx, then spinal vertebral infection related to the head and neck, vascular space infection, the carotid and internal jugular, and orbital and paranasal sinuses, and finally we'll talk about infections of the cervical lymph nodes. There are two major causes of head and neck infection. In children, tonsillitis is considered the most common cause for infection in the head and the neck, while, as I have mentioned, the tooth infection or the odontogenic origin of inflammatory process is one of the most common causes in adults. Then in about 20 to 50% of head and neck infections, there is no identifiable source for this infection. The infection, especially noted in immunosuppressed patients, may have the increased frequency, recurrent attacks, and the presence of atypical organisms, and they are more prone for some of the complications. And there is a very big list for head and neck or deep neck infections. And as they have mentioned, the tonsils are responsible for the major role in children. Dental infection are responsible for the major role in adults. Then you can include all of these like oral surgery, endoscopic instrumentation, foreign bodies, intravenous drug abuse, and the presence of infection elsewhere in the body, like in the mastoids or the salivary glands, also considered the factors of trauma. All these can contribute to the inflammatory changes in the head and neck. Then we start by the dental infections, which of course will spread to the nearby soft tissues, including the floor of the mouth. And these infections result from the formation of abscesses around the root of the tooth, and patients with odontogenic source of infection may complain of pain, edema, and virulent discharge, which is usually localized to the site of the lesion. And in many situations, the patient may have fever, and many times there are tender, slightly enlarged cervical lymph nodes. And this is an example of a dental periapical abscess. In the bone window image, and you see there is a small area of osteolysis surrounding the apex of this tooth, and there may be some cortical disruption here, and this will result in the spread of infection to the adjacent soft tissues, which are here now representing the mouth floor muscles. And I hope you remember their names from the previous lectures, you know the GG or the genoglossus muscle, and lateral to it the mylohyoid muscle. Between the genoglossus and the mylohyoid there is the sublingual space, and outside the mylohyoid there is the submandibular space. Then many times, as I have mentioned, the knee are confronted by slightly enlarged deep cervical lymph nodes and also nodes around the submandibular salivary glands, and these are usually referred to as reactive lymphadenopathy. And here you can see an example by plain X-ray. This is the socket of the third molar tooth, and if you look carefully, there is a rarefaction of the bones surrounding this socket compared to the extracted opposite molar tooth with a clear cortical outline. And this haziness is highly suggestive of a superadded or the presence of infection at this place. And if you look here, you see the socket of the molar tooth is rarefied, is eroded. There is partial destruction of the cortex and consequent spread of the inflammatory process to the adjacent pterygoid muscles. You remember this is the mandibular ramus, and this is the parotid gland, this is the masseter muscle, and here the pterygoid muscles, and this is the parapharyngeal space fat, and this is the oropharynx, of course. Then the complications of dental infection may proceed to upward to the paranasal sinuses, leading to sinusitis, or spread locally, leading to osteomyelitis, or spread to the mouth floor muscles, leading to angina, or extend into the deep neck spaces, or may reach the intracranial area, leading to meningitis and cerebral abscesses. And this is an example of a periapical abscess, and this abscess is intimately related to the inferior wall of the maxillary sinus, and the maxillary sinus is almost totally obliterated, denoting the presence of acute sinusitis, which is, in this case, the complication of this periapical abscess. And here you can see a submandibular space abscess, which is a hypodense lesion with a thick enhancing margin. And one of the important signs for inflammatory processes is the presence of a stranding or a smudging of the related subcutaneous fat planes. And here you can easily appreciate this stranding of the fat compared to the opposite side, and the infection is present in the submandibular space lateral to the mylohyoid muscle. This is the mylohyoid muscle, and this is the submandibular space. This is the submandibular salivary gland on the normal side, and here you can see this is the gland and this is the infection. Then in the bone window image, you can see the rarefaction of the bone around the root of the tooth, and here you can see cortical disruption of the mandible leading to the spread of the inflammatory process to the adjacent soft tissues. Then one of the important notes here is that one of the major differential diagnoses for this appearance is malignancy. And whenever the clinical picture is not conforming with an inflammatory process, then this lesion should be biopsied, and the possibility of malignant process should be excluded. And this is an example of an inflammatory process related to periapical abscess around this area of rarefied bone. And you see the soft tissue swelling, the areas of necrosis, the stranding of the subcutaneous fat, the spread to the buccinator muscle here, and many times, as I have mentioned, then you can see deep to the sternomastoid on both sides, these relatively small lymph nodes, which are usually in the range of 1 to 1.5 centimeter, and they frequently show homogeneous contrast enhancement. They are referred to as reactive inflammatory nodes. And here is a submandibular abscess, which is located very close to the submandibular salivary gland. This is the submandibular salivary gland, which is swollen, and lateral to it there is an inflammatory node which contains some necrotic centers inside. Then you see the abscess cavity, which is a marginally enhancing lesion, and you look to the surrounding fat planes, and the fat planes subcutaneously they show the stranding of the subcutaneous fat. And this is another example which represents a big abscess in the parapharyngeal space region. Here, this is the parapharyngeal fat on the right side, which is good. And here you see a big lesion, which is mainly of fluid density, containing some air loculi, and is related to an inflammatory lesion in the adjacent mandible. And if you look carefully, then you see some of the stranding and obliteration of the subcutaneous fat. The coronal images are good for detection of reactive lymph nodes. And here you can see deep to the sternomastoid muscle a series of slightly enlarged, homogeneously enhanced lymph nodes seen on both sides. And these are also reactive cervical lymph nodes. Then we came to the Ludwig angina, and this is an inflammatory, rapidly progressive process involving the mouth floor, leading to soft tissue edema of the tongue and mouth floor, and this will lead, of course, to rapid airway compromise. And this process may be fatal if not managed thoroughly, and most of the cases are usually related to odontogenic infection. Usually, we do not need the help of imaging to diagnose Ludwig angina, since this is primarily a clinical diagnosis. But sometimes we may need the help of CT or ultrasound to assess the extension of the inflammation and to assess the presence of abscesses which may need surgical drainage. And if you look here and you see that the mouse floor is no more that floor, with almost loss of the fat planes between the mouse floor muscles, which are turned here into a hazy, big, swollen mass with some areas of fluid density inside, and very importantly, the encroachment on the airway. And there is significant compromise of the oropharynx. And as I have mentioned many times, you can see these reactive lymph nodes, either deep to the sternomastoid or related to the submandibular salivary gland. This is the submandibular salivary glands, and this is the reactive lymph node. In here you see another one, and another one deep to the sternomastoid muscle. If you compare the normal anatomy by the appearance of inflammation of the mouth floor, and you see here you can identify the midline fat septum between the genioglossus muscles, and you can identify fat lateral to the mylohyoid muscle, and you can see clearly the submandibular salivary gland. But here you cannot see any of these, and this is the magnification of the same pictures, and this is the normal appearance of the anatomy. And here you see diffuse swelling of the mouth floor, encroachment on the airway, loss of the normal fat planes. And this is another case where you can see diffuse swelling of the mouth floor muscles and loss of the normal fat planes, significant encroachment on the airway. And sometimes you can see these reactive lymph nodes, as I have mentioned. Then this is the normal section, and just to compare the clearly identified muscles and fat planes with this appearance of Ludwig angina. Then, as I have mentioned, this angina is a clinical diagnosis, and we may sometimes need imaging to evaluate the integrity of the airway and to assess the presence of gas-forming organism, to detect the underlying dental infection, and to look for abscesses, which should be surgically drained sometimes, and to detect or to look for the reactive or suppurative lymphadenopathies. And this is a case of loop angina. You see an abscess in the soft tissues below the mouth floor, and the abscess is marginally enhanced. You see the infection of the root of the tooth, rarefaction of the uh, inner cortex of the mandible, and you can easily appreciate the reactive lymphadenopathy of both sides. And this is also another case with a swelling of the floor of the mouth. This is the submandibular salivary glands. The airway is markedly compromised, and this is the nasotracheal tube, and you also see the nasogastric tube. This is also an example of an abscess in the sublingual area, where you can see this is the genohyoid muscle, and the abscess is located here. It is small with a thick enhancing margin, as you can see in the sagittal reformatted image. One of the leading causes for tongue and oral cavity infection is the tongue piercing, and many times this instruments may lead to a localized infection, and this infection will progress to form a big abscess in the tongue. And you know the tongue is very rich in the blood supply and is resistant for infections, but this material may lead actually many times, and then you can see here they may injure the tissue of the tongue and lead to the introduction of an inflammatory organisms. And this is lingual and sublingual abscess, where you can see very big abscess in the mouth floor involving predominantly the tongue as well as the genoglossus muscle. There is obliteration of the normal fat planes. They can see air loculi within the lesion. Then we came to the tonsillitis, which is the major inflammatory source for infection in the children and the young adults. The patients will present by painful throat, dysphagia, fever, and many times with tender cervical lymphadenopathy. And then if you look in the mouth of the patient, and you see that the tonsils are swollen and they are uh, sometimes covered by pus. The, uh, the lesions involved in tonsillitis are mostly bacterial, but may be viral, such as the herpes or cytomegalovirus. Then usually in cases of tonsillitis, you do not need the help of imaging as well, but the imaging is needed if there is a doubt about the diagnosis and you feel that this is not tonsillitis but another inflammatory lesion, inability to examine the patient, or whenever you are afraid about the presence of complications. Then the CT appearance of tonsillitis is very characteristic. And you'll see that the tonsil is enlarged, and both tonsils, if they are enlarged, they may touch each other across the midline, what is known as the kissing tonsils. And if you give intravenous contrast material, characteristic pattern of enhancement is seen in cases of tonsillitis, which is in the form of horizontal streaks across the involved tonsil. And this is a very good example of tonsillitis on the right side and the development of tonsillar abscess on the left side. This is tonsillitis. The both tonsils are involved. You see the streaky enhancement of the involved tonsil. This is very important to differentiate enlarged tonsils due to tonsillitis from enlarged tonsils due to neoplasm, for example, like lymphoma or squamous cell carcinoma in many times. This pattern of enhancement is highly suggestive of tonsillitis. Then complications, a spread of the infection to the peritonsillar area, forming an abscess or extension into the retropharynx, leading to a retropharyngeal abscess, may extend to the ear across the Eustachian tube, leading to otitis media, or sometimes whenever they are kissing, they may lead to obstructive sleep apnea. And this is a good example of bilateral tonsillitis. The tonsils are swollen, showing the characteristic enhancing pattern, and you see the reactive lymphadenopathy on both sides. And this is an example of a tonsillar abscess on the right side. And here you see a marginally enhancing lesion in the anatomic site of the tonsil related to the medial aspect of the parapharyngeal space fat. And also you appreciate the presence of reactive cervical lymph nodes. In patients with infectious mononucleosis, one of the stigmata of this disease is the presence of significant enlargement of the tonsils, which are inflamed and being in contact or may touch across the midline, leading to the kissing tonsil appearance. Then one of the abscesses or the inflammatory lesions in the neck is the retropharyngeal abscess. And this retropharyngeal abscess is usually seen in children, and most of them are below the age of 5 years. And here, in these patients, there is prominent retropharyngeal lymph node tissue, and the frequent middle ear and the nasopharyngeal infections are contributing to the prevalence of retropharyngeal abscesses in the pediatric age group. Then the clinical presentation is usually by fever and painful swallowing sometimes, and you got neck swelling due to lymph nodes, and sometimes stridor due to compromise of the airway. And also you may have palpable cervical lymph nodes. And the primary infection may be present in the nasopharynx, in the paranasal sinuses, or in the middle ear. The infective organisms are Streptococci, Staphylococcus aureus, Haemophilus influenza, anaerobic organisms, and of course TB in endemic areas. And these inflammatory organisms may have an access to the retropharyngeal lymph nodes, which are then inflamed and suppurated, then may extend in the craniocaudal directions to the skull base or down to the mediastinum. And the retropharyngeal abscess is diagnosed if it is large by the plain X-ray of the cervical spine, the lateral view. Usually, you know that the prevertebral soft tissue shadow opposite the upper cervical vertebrae from C2 down to C4 should not exceed 1/3 of the vertebral body, one third of the vertebral body width. and the prevertebral soft tissue shadow opposite the lower cervical vertebrae should not exceed the width of the cervical vertebral body. Then in this particular example, you see a very big retropharyngeal soft tissue, which has increased the distance between the air in the pharynx and the cervical spine too many times. And of course, you can easily appreciate the presence of air loculi, which are highly suggestive of the presence of an inflammatory lesion, especially the abscess. Then, widening of the prevertebral soft tissue strip is one of the diagnostic clues in the plain X-ray. And here you can see a retropharyngeal abscess showing the classic criteria of a cystic lesion, hypodense with thick enhancing margin, and the related soft tissues are swollen with obliteration of the fat planes. Then you can compare these changes by the opposite on the normal side. You see the fat planes, and you can easily separate the muscles from each other. Then complications of the retropharyngeal abscess may spread posteriorly, affecting the spine, leading to discitis, osteomyelitis, and spread of the infection inside the spinal canal. And the lateral extension is very dangerous because it will lead to a parapharyngeal abscess, which is intimately related to the carotid space, and it may affect the carotid artery or may affect the internal jugular vein. Then, if the abscess extends anteriorly, it will compress the airway. If it extends inferiorly, it may go inside the mediastinum, leading a serious complication, which is mediastinitis. Then, also systemic dissemination may occur. And this is a retropharyngeal abscess by Belain film. And you see enlargement of the prevertebral soft tissue shadow, multiple air loculi inside the lesion. And this is the CT showing the lesion with marginal enhancement and air loculi in the within the abscess, which is compressing the airway, as you can see. And the retropharyngeal abscess may extend to is usually located posterior to the pharynx, but uh, may extend, as I have mentioned, up and down. And the CT scan is the diagnostic way or the diagnostic way of choice for evaluation of the size and the extension of the abscess, and also if there is internal air loculi and associated complications. And this is a retropharyngeal abscess, which is multilocular of tuberculous etiology. If you look here, and this is the spine, C2, C3, and C4 are involved by osteolytic process with involvement of the intervening disc and associated big soft tissue abscess cavity, which is better seen here in the axial image and also in this sagittal soft tissue window image. The erosive changes in the vertebrae is well appreciated in this axial image as well. Then tuberculous spondylitis with retropharyngeal abscesses or mediastinal abscesses are well known. And this is an example of tuberculous spondylitis. And here you see involvement. It is T2, C3, C4, C5, and C6, as well as the disc space in between. This is T2 weighted image, and this is T1 post contrast. You see enhancement of the inflammatory tissue and the presence of prevertebral retropharyngeal abscess cavity, which is of bright signal in the T2 and shows marginal enhancement in the post-contrast image. And retropharyngeal abscess may spread, as I have mentioned. This is the abscess, multilocular, posterior to the pharynx, and there is an extension into the posterior neck space on the left side. Parapharyngeal abscesses are a very serious condition because of its intimate relation to the carotid sheath. And this may affect the internal carotid artery, may affect the common carotid artery or internal carotid artery or the internal jugular vein. The symptoms will include fever, sore throat, nasal voice, dysphonia, and cervical lymphadenopathy. Then spread to the parapharyngeal abscess may came from tonsillitis, may, may result from bursting of the pretonsillar abscess, may occur secondary to apical petrositis, or may be the sequelae of infection in the mouth floor. And you remember that a retropharyngeal abscess may spread laterally into the parapharyngeal area. Complications are serious, and they include jugular thrombophlebitis with septicemia. This is a very dangerous complication, and weakening of the carotid wall, leading to mycotic aneurysm, and this aneurysm may rupture what is known as carotid blowout with massive hemorrhage. Then the abscess has the similar way of spreading into the retropharyngeal space, downward into the mediastinum, and of course into the carotid area. And this is the parapharyngeal abscess. The abscess is located posterior to the parapharyngeal fat, and it shows the classic appearance of an abscess, cystic lesion, marginally enhanced, and many times you see the reactive cervical lymph nodes deep to the sternomastoid muscle in the axial image around the submandibular salivary glands sometimes. And this is a parapharyngeal abscess by MRI T1, and before and after contrast injection. You see a big abscess which is extending into the retropharyngeal area, and it is also intimately related to the carotid space. And this is the coronal image showing beautifully the extent of the abscess in the parapharyngeal area. And one of the inflammatory lesions in the neck is the acute epiglottitis, which is considered uncommon, and the incidence is about 1 every 100,000 per year. And the epiglottitis is a disease of adults in most of the cases, and it presents usually in the fifth decade. The epiglottitis is more common in countries where they do not immunize against the Haemophilus influenza virus. And the mortality rate of epiglottitis is in the range of 6% in adults, while it is less than 1% in the pediatric population. This is the normal appearance of the epiglottis in the lateral X-ray of the neck, and you see the size of the epiglottis, the preservation of the pre-epiglottic air and the retroepiglottic air. But here, when the epiglottis is diffusely swollen, it will obliterate the air column both anteriorly and posteriorly, as you can see here. And the symptoms will include the sore throat and dysphagia, fever, drooling, cervical lymphadenopathies, stridor, respiratory distress, and this is a frequent position which is known as the tripod position in the children, which is reflecting the respiratory distress of the patient, sitting up on the hands with the tongue out and the head is projecting forward. And the diagnosis of epiglottitis is usually easy clinically, and it may not need the help of imaging, but the plain film can see the swollen epiglottis, which is compromising the related airway. Sometimes you need the help of CT to detect the extent of airway compromise, to detect the presence of abscesses or inflammatory lymphadenopathy, to exclude the presence of other inflammatory lesions associated with this process, and to look in the supraglottic area to look for the tongue base, for the soft palate, for the valleculae, to see if the infection has spreaded for these areas. Then the usual way is to have a plain X-ray and to do a direct laryngoscope. But if this laryngoscopy is difficult or cannot be performed, then CT may be of help. And the CT scan, you will see that the epiglottis is inflamed, and sometimes you can see air loculi within the inflammatory mass. And in this particular case, and you can see air spreading in the facial planes of the neck as well. And in the lateral view, you can see the swelling of the epiglottis compromising the airway. And this is sagittal reformatted image, and this is the axial image showing diffuse swelling and the heterogeneous enhancement of the epiglottis, considerably encroaching on the airway. The sagittal image is very informative, of course. In another example of acute epiglottitis, you see the epiglottis, which is swollen and edematous. You see the encroachment on the airway, and in the coronal image, you see this is the epiglottis, which is swollen, and the spread of infection along the airy epiglottic fold, reaching the region of the arytenoid cartilage. And you can compare this with the normal appearance of the left airy epiglottic fold, the preservation of the paraglottic space. Then this is usually simulated by the thumb, and if you look here, and this is what I mean, this the swollen epiglottis, which may look similar to this thumb. The organisms are, of course, the Haemophilus influenza, the Staphylococci, Streptococci, and viruses. Then for the evaluation of the epiglottitis, the plain film and the clinical data are usually enough. Direct laryngoscope may look at the lesion. CT is reserved for the complicated cases looking for the spread of infection to other places. The treatment includes intubation or immediate formal tracheostomy or cricothyroidotomy in order to ensure a patent airway. But if the patient have no signs of significant airway compromise, they may be managed without immediate airway interventions, without this tracheostomy, for example. Then we came to an issue which has been discussed before, the laryngeal, the thyroglossal duct cyst, and the branchial cleft cyst. All these lesions may be secondary infected, leading to the formation of abscesses, as I have mentioned before. Then laryngeal, whenever it is secondary infected, it will be transformed into an abscess with marginal enhancement and fluid density inside. And you remember we have three types of laryngeal: the internal one, which is confined to the larynx, the external one, which is outside the laryngeal structures, and the mixed laryngeal, which has an internal component and an external component. Then you remember that the thyroglossal duct cyst is almost the only midline cystic lesion in the neck, which is related to the course of the thyroglossal duct, starting from the foramen cecum at the back of the tongue, downward along the anterior aspect of the hyoid bone and the thyroid cartilage until the final destination of the thyroid gland in the lower part of the neck. Then this descent course is liable for the formation of cyst or the fistula or sinus, and frequently you see a cystic lesion which is embedded in the strap muscles, usually located at or just below the level of the hyoid bone, and this cyst is in the range of 2 to 4 centimeter in diameter. If this cyst is secondary infected, you got an abscess and the marginally enhancing lesion, which is almost exactly in the midline, is suggestive of an infected thyroglossal duct cyst, and you can see the stranding of the surrounding and in the subcutaneous fat planes. And this is also an infected thyroglossal duct cyst, which is located anterior to the hyoid bone. The cyst showed marginal enhancement. Of course, if the cyst is not infected, you do not see marginal enhancement and you do not see air inside the lesion. And here you can appreciate the presence of reactive cervical lymph nodes, which are discrete, homogeneously enhanced, and in the range of 1 to 1.5 centimeters. The second branchial cleft cyst may also be infected, and you remember that the second branchial cleft cyst is the commonest cyst of the all branchial arches, and is located exactly posterior to the submandibular salivary gland, anterior to the sternomastoid muscle. This is the usual location of the second branchial cleft cyst. And sometimes this cyst may have a tongue-like projection between the internal and external carotid artery, which is considered by many as one of the pathognomonic features. Then if you see a cystic lesion in this particular area, posterior to the submandibular salivary gland, anterior to the sternomastoid muscle, you may think of a branchial cleft cyst second arch. And if this cyst is marginally enhanced, and if the fat planes around are stranded, then you know that you are dealing with an infected second branchial cleft cyst. Uh, thank you very much. هذا وبالله التوفيق والحمد لله رب العالمين, and we'll continue